Erica Barnes is someone who wears many hats in our community. We introduced her, and her slide here says she's the executive director of the Minnesota Rare Diseases Advisory Council, or the RDAC. But she has a lot of other titles and hats in our community also. So she's a certified speech language pathologist who helps lead the RDAC in Minnesota, and I think helped lead the passage of the legislation that established the RDAC in Minnesota, if I'm not mistaken. And she has over a decade of advocacy and nonprofit leadership experience. She and her husband co-founded Chloe's Fight Rare Disease Foundation in honor of her daughter, Chloe. In addition to her role as council administrator, she chairs the NIH-funded Global Leukodystrophy Initiative Clinical Trials Network, or GLIA-CTN, which is a consortium, a patient advocacy group consortia out of NIH. She also is very passionate about newborn screening, applying health economic understanding to shortening the diagnostic odyssey in rare and informing decision-making in our rare disease space. And it's really been a pleasure to work with her on a number of initiatives in those areas. And she cares very passionately about improving care for the rare disease community and addressing a lot of the barriers to care in our community. So I'm really pleased to introduce Erica, who's going to talk a little bit about the RDACs and other opportunities for engagement at the state level. So Erica.
Thank you. Thank you, Annie, so much for inviting me and for giving me that introduction. And so by the end of this presentation, I really want the listeners to understand just what are the RDACs, just kind of general information about rare disease advisory councils. They're relatively new, so give a sort of a general overview. What are the roles and responsibilities of rare disease advisory councils? I'll dig a little bit more deeply into the state of Minnesota because that's the one that I am the executive director for, and then end with how stakeholders can engage with the rare disease advisory councils and/or ways that we've in the state of Minnesota have built out ways for individuals to engage with our RDAC. So this is a picture, one of my very favorite pictures in the whole world. This is a picture of the coalition that worked to pass the Rare Disease Advisory Council in the state of Minnesota. We passed this piece of legislation in 2019. The legislation called for the creation of a Rare Disease Advisory Council. It was passed unanimously, and it ended up being a coalition of 42 different organizations. And I'm really proud of that because these 42 organizations, the coalition was made up of patient advocacy groups, hospital systems, medical associations, and industry partners. So it really truly was a very diverse coalition. It was very grassroots. I'm looking at this picture and I'm seeing families whose children were affected by rare blood diseases, some families whose children were affected by neurological diseases. So really a very truly diverse group of individuals that came together to pass this bill. So that's our council. Next slide. And now I kind of want to take a step back and give you a broad overview of the movement of the rare disease advisory councils. I know there are people listening to this, obviously, that are not from the state of Minnesota. So I want to give kind of a broad overview of the progression and the evolution of rare disease advisory councils. So the first Rare Disease Advisory Council to pass was passed in North Carolina in 2015. It was passed by an amazing advocate whose child had been affected by Batten's disease. And in 2015, after it passed, it was housed at the University of North Carolina and chaired by a University of North Carolina professor. That particular Rare Disease Advisory Council at the time was relatively small. I think there were 6 professionals on it. But it was passed in 2015. Minnesota began the process of establishing a Rare Disease Advisory Council in our state in 2018. We began the process, and at the time, we had a lot of decision-making to make around whether or not we would put it in the Department of Health or whether we would put it in an academic setting. Our council the final decision was to put it in at the University of Minnesota. So it's in an academic setting right now. We also decided to make even though we sort of used the template of the North Carolina Rare Disease Advisory Council, we decided to put a lot more council members representing different job descriptions on our council, so made it quite a bit more robust. I'll talk about that later. And currently in the United States, there are over 19 RDACs. Actually, today, I believe I read that there are 21 formal rare disease advisory councils. And these are the states that have passed rare disease advisory councils. Forgive me, I couldn't find a map that had the name of states printed on it. So you'll have to dig into your, high school geography to decide which states, to figure out which states have advisory councils. You'll have to use the shape of the state. So 21, and this map sort of underestimates the whole movement, because there are also states that are in process of getting a rare disease advisory council passed that's working on that legislation, whether it was introduced in this legislative session and it's still pending, or if it's advocates have tried to pass it a couple of times and it just hasn't passed yet. So there's a number of states above this formal number as well, and a handful. One thing that I really want to make clear about rare disease advisory councils, because it has some implications, is that these councils are legislatively established. So because they're legislatively established, that means it requires legislation to get these established. And of course, passing legislation can be a whole task in and of itself. It requires coalition building and engaging with legislators. So it's important that if you're listening and you don't have a council established in your state, it's important to know that that would be something that you would need to pursue through the legislature. And it involves, finding chief authors, finding co-authors, and it's a pretty involved process. Another point that I really want to make about these councils, because it explains some of the variation from state to state, the wide variation from state to state. The establishment of these councils has been really grassroots and relatively recent, as you see. So because these are kind of grassroots at the state level, there's a lot of variation in how each state is operationalizing their council. So therefore, the goals and duties and structures vary from state to state. Most of them are housed either in a Department of Health or in an academic center. And then a few of them have a commission model, and they're very time boxed. So there's a wide variety depending on what state you live in. The last point to make is at least at this point, relatively few of these councils have a fiscal component. So most of these councils are being staffed and being populated by amazing individuals who are doing it on a volunteer basis. Next slide. So now I just want to give a little bit of an overview of the duties of most of the councils. And again, like I said, I'm going to probably be saying it throughout the presentation. I want to always hedge what I say to say that each state is different, and I can't guarantee that if you're listening and you have a rare disease advisory council in your state, that what I tell you sort of encompasses your council. But for the most part, this table lists out the duties that most of the councils are using in their legislation. And I want to just run through it quickly. I'll explain what's highlighted in green in just a second. But first of all, I just want to run through a few of the duties. One of the duties that is established in most councils is the development of resources. And this is usually, these resources and gathering resources is usually related to diagnosis, treatment, and education about rare diseases. Partner stakeholders in the legislation or that have been identified, at least we've identified in the state of Minnesota, is developing these resources in conjunction with medical schools and schools of public health, as well as hospitals and patient advocacy groups. The next duty listed in a lot of the legislation is identifying best practices for care implementation for rare diseases. Obviously, this is a very heavy lift. There's lots of rare diseases. So partner stakeholders in terms of developing and identifying best practices can be the medical community and the patient advocacy groups in a state. Another duty is to collaborate with and other states and rare disease advisory councils. In our particular legislation, we have a mandate to collaborate with other states and to find out what's going on in the national and international level so that we can inform our best practices. Another duty, and the reason that I highlighted this one in green is it really speaks to the grassroots nature of developing this legislation. So we have a duty in our legislation to identify how to remove obstacles for patients when they're looking for a health plan and improve the ease and speed of finding a new health plan. That particular mandate was put in the legislation because a woman whose child had cystic fibrosis was having extreme difficulty when she changed her job, and she reached out to a state legislator. It hit her, and she was his constituent, and he advocated for getting this particular duty put into the legislation of the council. So it really speaks to the power of advocacy and the power of engagement, that actually made it into the mandate of our legislation. Another duty of our council is to make recommendations in terms of strategies for diagnosis and treating rare diseases. Obviously, stakeholder partners can be the medical community, patient advocacy groups. Another duty is developing information and programs to raise awareness for the rare disease community and develop educational programs for diagnosis and treatment. This one in particular also calls that we would advise, consult, and cooperate with state agencies. And so we've engaged with DHS, MDH, and other agencies of state government. The Newborn Screening Advisory Committee is another entity of the state that we've worked a lot with, and we're currently working on some programs and ways to support the newborn screening program. And then the last one is collecting additional topics for further study and evaluation. And we've worked really hard to make sure that we have avenues for collecting information from the patient advocacy groups and the public. So again, those duties are kind of general duties that you'll find in a lot of state rare disease advisory councils. But for the state of Minnesota, we worked right away to develop our own strategic plan. And we developed a mission and a vision. And then we established 4 pillars of action for our Rare Disease Advisory Council. So our mission is just built right off of the legislation to provide advice on research, diagnosis, treatment, and education related to rare diseases. And our vision is that in Minnesota, every citizen in Minnesota who has a rare disease has access to timely diagnosis, expert and coordinated care, and individualized treatment and management throughout their lifespan, not just when they're in pediatrics and pediatric health systems, but even in the transition to adults. We are doing that. We're really framing it around approaching the rare disease community through a population health lens. So really taking time. We did a survey where our goal was to really, we know that rare diseases are very heterogeneous and there's over 7,000 patient populations. So meeting the needs of each individual community can be difficult. So we're really taking a population health lens and looking for those common barriers to care that you see across rare diseases. And we established 4 pillars to sort of represent that and represent those barriers. The first one that we established, and really this one shouldn't be a standalone pillar, it sort of infuses all we do, but it's deepening and increasing our understanding of the needs of the rare disease community. The next one is coordinating care for the rare disease community, addressing all the issues with coordination of care, reducing time to diagnosis, and then accelerating research. Next slide. So I talked a little bit about the duties. I also want to talk a little bit about the structure of rare disease advisory councils. So in the state of Minnesota, our membership is on the left-hand side, you see a map of where our membership comes from geographically in the state of Minnesota. So we have representation, and the stars are actually the health systems that are represented on our council. So as you can see, there's 4 stars kind of concentrated in our metro area, but it was very important to us to make sure that we were getting out to greater Minnesota. So we have council members that also come from more greater Minnesota, northern Minnesota, and more southern Minnesota, because we wanted to make sure that we were getting information not just from concentrated in the metro area. Our membership, I believe we have 24 different positions on the council. So it's a large council. It's very multi-sector. When people say, wow, you have a really large council, I say, yeah, we have a really large, we have a lot of large needs in our community. So we need the input from a lot of different stakeholders. So at the bottom of that, the highest number on our council are patients and patient advocacy groups. So we have 3 positions for patients and one position for patient advocacy groups. In addition, we've been fortunate to find some of the other roles on the council. We have found individuals who are professionals and also are patients living with a rare disease. So we have one medical provider who also has a rare disease, and our industry representative also is an individual living with a rare disease. So really wanting to get that patient representation on the council. The next level of membership we have are clinicians and direct service providers. So in addition to doctors that directly treat individuals with rare diseases, we also have social work and nursing and pharmacy represented on the council. And then at the top, we have legislators who are also members of the council, and hospital administrators, so sort of that hospital leadership, and industry. And when I say industry, it was very important to us that we have both the pharmaceutical industry represented and payers. So a very diverse group of people and a very large council. Next slide. And then I'm not going to belabor this because I already talked in depth about this slide a little bit earlier, and I'm trying to be cognizant of the time. But again, these green, the green on the column and the row across shows how we as a council in Minnesota have really worked to take sort of those duties that tend to span all the RDACs around the country and really make them our own, and really take those pillars that we identified and try to sync them to the duties of the legislation. And this is really an effort, and the intention is to be very comprehensive in the way that we're approaching the needs in the community and really staying rigidly focused on identification of common barriers to care. Next slide. So once we had our duties established and once we started the work, it was very important to us that we make sure that there were lots of opportunities for engagement of our stakeholders. This council started as a grassroots movement, and we want it to stay that way. And we want to make sure that we are as open as we possibly can be, and we're really listening to the voice of the patient and providers and all stakeholders, anyone who's interested in improving care for the rare disease community. So the first opportunity that we have for engagement with our community are meetings. So we hold quarterly council meetings, and even though we're not officially held to open meeting laws, we follow the ethos of open meeting laws. So we make sure that when we establish our quarterly council meeting, we let the community know that we'll be having those meetings, and we invite the community. Currently, they're virtual, so that makes it easy for people to attend. So we just make sure that those are open to the public. In addition to that, we have work groups that meet monthly. Actually, some of the work groups even meet twice a month. In addition to the work group members, we have opportunities. We have a couple of the work groups that actually have participation in the work group from individuals that are not officially on the council, are not council members, but they're very engaged stakeholders. One gentleman that we have in one of our work groups is phenomenal, and he's got expertise in marketing, and he has helped us so much. So even though he's not an official member of the council, he's very passionate, and he's been a huge asset to the council. The next area that we've developed as opportunities for engagement are surveys. So we conducted right away when we started the council, one of our first initiatives was to conduct 2 surveys. And the reason, and we had one survey is a patient and caregiver survey, and the other survey was a clinician survey and a frontline provider survey, because we really wanted to make sure that we were getting perspectives from both patients and from clinicians. We understand and suspected that there could be a mismatch in perceptions among the general medical community about the urgency of addressing rare diseases, about the needs of the community. There could be a disjunct between that perspective and the perspective of the patient. So we really wanted the opportunity to explore that and unpack that. Our patient survey actually yesterday just got published in Orphanet. So anyone can go look at that survey and see the information that we gathered. Unfortunately, we did conduct a provider survey during COVID, so we didn't have as high a participation from our frontline providers as we would have liked. But we did get some valuable information, and we're still kind of unpacking that one. The third opportunity for engagement, and that this one actually is exciting, and it's going to be going into 2023, all of 2022, and maybe 2023 are a set of performances that illustrate the rare disease journey. It's a really exciting thing. The University of Minnesota Theater Arts Department is partnering with the Center for Orphan Drug Development Research. And what the Theater Arts Department did is they had a senior level class in which it was a workshop for the students, and in which they actually wrote a play. They adapted a Greek tragedy, and they built it around the experience of living with a rare disease. So the process was so exciting. The council and other stakeholders worked with these students, kind of immersed them in information about the rare diseases. They listened about rare diseases. They listened to lectures. They met with patient advocates, caregivers, and individuals living with a rare disease, and just sort of absorbed their stories. And then they produced their play. The next phase of it will be that the playwright who helped them is Kevin Kling. He's a professional playwright. If you've listened to NPR, he's been a regular contributor. He's going to take the work of the students and build on it some more. And then a theater company in Minnesota is going to actually turn it into a professional production and tour it all around the states. They currently have 9 different locations right now. So that's exciting. We have invited the patient communities in addition to the patients who contributed to the play. And then the last opportunity for engagement that we built out over the last couple of years is a number of organizations. One of the organizations that the council helped get off the ground was a new NORD Students for Rare Minnesota chapter. So the very first chapter of a Students for Rare on campus. And I get to co-sponsor that wonderful organization. So that's the Rare Disease Advisory Council. I tried to give you a little bit of information generally about the movement and specific to Minnesota. So thank you so much.